Okay, so I think we'll begin. Thank you so much, everyone, for joining us today. My name is Amy Sam. I am the Health Education Project Specialist at the Maxwell and Eleanor Blum Patient and Family Learning Center at Mass General Hospital. Today's program is part of our dermatology series, which is a special collaboration between the Blum Center and Department of Dermatology. Before we begin, just wanted to go over a few items with you all. Please be aware that today's session is being recorded for educational purposes. If you're interested in viewing the recording, you can visit our Blum Center website at massgeneral.org/Blum-Center. Please note everyone is in listen-only mode. Everyone has been muted so that we can hear our guest speaker today. If you have any questions for our guest speaker, please use the chat feature, which is located at the bottom of your screen. We'll have time for them in the end. Only Blum Center staff and the guest speaker will see them. Please do not share any personal medical information or questions in the chat box. If you have a personal medical question, please ask your doctor. Okay, Dr. Fedeles, would you like to share your screen?
Sure.
So next, I would like to introduce you all to Dr. Flavia Fedeles. She is a clinical dermatologist in the Department of Dermatology at Mass General Hospital. She is also an instructor in dermatology at Harvard Medical School. Dr. Fedeles sees patients in general dermatology clinic, but also in our combined rheumatology dermatology clinic, where she sees various inflammatory diseases of the skin, including psoriasis. She has a special interest in complex medical dermatology and connective tissue diseases. She joins us today to give a presentation on psoriasis. So please join me in welcoming Dr. Fedeles.
Thank you so much for that introduction. I'm very excited to talk to you about psoriasis. As Amy mentioned, I do see patients in our general dermatology clinic as well as in our rheumatology dermatology clinic, where we do see complex medical dermatology patients, including patients with psoriasis who also might have psoriatic arthritis and some other diseases related to psoriasis. So I'm very excited to talk to you about psoriasis. And let's see if I can advance my slide. So I have no disclosures for this talk. I just want to emphasize that the contents of this talk are purely educational. So if you have psoriasis or someone in your family has psoriasis, you should consult a board-certified dermatologist for medical advice. And also, these are not photos in the presentation of my own patients. These are from various resources, including textbooks, as well as some online resources. So the goals of this talk today is really to understand some of the clinical findings in psoriasis and diagnosis, to understand some of the other diseases that psoriasis can be associated with. And these are called systemic associations, and to understand some of the treatment options that are available. We are just going to briefly touch on all of these topics. This is just kind of like the roadmap of my presentation today. I do want to focus the second part of the talk on the treatment because I think that's important. So let's talk about psoriasis. So what is psoriasis? When we think about psoriasis, this is what we think about. So there are skin lesions that are red, thickened, dry, and scaly. And we call these lesions, these are patches on the skin, we call these lesions plaques. The skin is not normal in these plaques of psoriasis. As you can see in the schematic, normal skin on the left and psoriasis skin on the right, the skin is thickened in psoriasis. There is a lot of more proliferation of the skin. The skin accumulates the skin layers, and this results in that thickened appearance. And then the scale on top. The blood vessels are also abnormal. The blood vessels are bigger, they're more twisted, dilated, and this results in that reddish appearance of the psoriasis spots. So psoriasis is an inflammatory disorder, and it affects a lot of people. Estimates are about 2 to 3% of the population, the total population. So that's about 125 million people. The number of people in the United States and Canada, the prevalence a little higher, has been reported about 4.6, 4.7%. So in US, about 8 million people living with psoriasis and about 150,000 new cases per year. So it's very common. A lot of people living with psoriasis. 2/3 of all cases are mild, while about 1/3 of the cases are severe. So what does that mean, or how, when we think about severity of psoriasis, we oftentimes think about the body surface area affected. So the surface area of the palm, for example, is considered to be about 1% of the total surface area. And in mild psoriasis, there is less than 3% of the body that has psoriasis. In moderate psoriasis, about 3 to 10% of the body is affected. And in severe psoriasis, more than 10% of the body has psoriasis. It can appear at any age. So we do see a variety of ages from infancy till the elderly. Interestingly, there are 2 peaks of incidence, which means that the majority of the cases are distributed in these age groups, 20 to 30-year-olds and 50 to 60-year-olds. 3/4, so 75% of all patients, they do have the onset of psoriasis does happen before the age of 40. And it affects equally men and women. It tends to have a chronic course, so that means that it persists for periods of time, long periods of time. There are intermittent remissions possible, so sometimes it can go away on its own and just stay away for a period of time, sometimes weeks, months, or even years sometimes. So let's talk about what psoriasis is not. So this is important. It's not just a skin disease. I'm going to talk to you a little bit about some of those other diseases that can be associated with psoriasis. But we definitely think now that when there is a lot of inflammation on the skin, most likely there probably is inflammation inside the body as well that can affect different body systems. It is not contagious. It's not an infection. This is not something that you can give to another person. It's also not an allergy. So this is not something that can, you eat something or you're allergic to something, it gets triggered. So it's not that. And unfortunately, psoriasis as of now is not curable. But we have a number of options, a lot of treatment options available. It can definitely be very successfully managed for long periods of time. So who gets psoriasis? The family history is very important. We definitely think that there are a number of genetic risk factors for people to get psoriasis. In about 35 to 90% of patients, there is a positive family history, which means that there is a first-degree relative that is also affected by psoriasis. The most common gene abnormalities are really in the immune system. So there's certain things that have been found, certain gene mutations that are more associated with early psoriasis or more severe psoriasis. In addition to the genetic risk factors, genetic predisposition, there are a number of triggers for psoriasis. Infectious triggers are common. We think of bacterial infections sometimes triggering psoriasis, most commonly streptococcal infections, but other infections have been reported, such as HIV. Stress is a big one. It can both trigger psoriasis and has been associated with flares of psoriasis. So we've definitely been seeing, with the stress of the past year, we're seeing a lot of patients with psoriasis flaring. A number of medications can also be associated with triggering psoriasis, and they're listed here. And finally, some lifestyle things like alcohol consumption, smoking have also been associated with triggering psoriasis. This is something that happens also where in psoriasis where injury to the skin can trigger it. This is called Kebner phenomenon based on the person who described it. About 1/4 of all patients with psoriasis do have this. And it can be any injury to the skin. It can be a cut, it can be a surgical scar, something along those lines. In this photo here, you can see someone who had a sunburn on the back and then developed psoriasis in that area of sunburn. Other things like any kind of rashes can also, psoriasis can appear in those areas of trauma to the skin. The clinical presentation of psoriasis is very diverse. There's a spectrum of manifestations on the skin. By far, the most common type is plaque psoriasis, and this is where this is what we spoke about or we talked about earlier, where we have these patches that are red, thickened, dry, and scaly, and you get this white scale on top of the plaques. We call it a silvery scale. So the features are erythema, redness, thickening, and scale. Most of the lesions tend to be circular, which means round, oval, or polycyclic, and the distribution is usually symmetric, which means on both sides of the body. Very commonly affected areas: elbows, knees, scalp, lower back, hands and feet, genitalia. There are different kinds of psoriasis. So plaque psoriasis is the most common form, but we do also see a lot of guttate psoriasis. This is a different kind where we do see patches of psoriasis, but they are very, very small. And this is extensively distributed, arms, legs, trunk. A lot of times guttate psoriasis occurs in response to an infection such as streptococcal infection. It's the most common type of psoriasis in children. We oftentimes test for infections because treatment, for example, if someone has strep throat and then it takes antibiotics, sometimes the psoriasis can go away in that particular situation. Postural psoriasis is another type of psoriasis. In this particular type, we do see a lot of pus lesions, pus bumps or pus blisters, which are the white spots in this photo. In a background of redness. And there's various types of postural psoriasis. This is rare, but sometimes it can be very extensively distributed, kind of like the whole body. It can be severe in those situations. Pustulosis of the palms and soles. This is really pustular psoriasis of the palms and soles, a type of psoriasis where most lesions are located on the palms and soles. And you do get these very deep blisters in the skin, as well as those whitish pustules, we call them, so those pus bumps that occur. Of course, this can really cause a lot of distress for patients because it is, the palms and soles are affected, and sometimes can be a little bit challenging to treat. Flexural or inverse psoriasis refers to psoriasis that appears in areas of flexural areas of skin. So, for example, in the armpits, under the breast, in the groin area, anywhere where there is a skin fold. In this situation, usually there are red, shiny plaques. They are very well demarcated, as you can see in this photo. And usually not so much scale in this situation. So again, this is another type of psoriasis. Sometimes is challenging to treat because of the locations, and because in skin fold, sometimes certain kinds of creams and topical medications can cause some irritation. Erythrodermic psoriasis is psoriasis that affects the whole body. So this can be very severe. It's actually a form that can be life-threatening. And essentially up to 100% of the body can be affected. And there's a number of triggers for this. Sometimes medications or withdrawal of medications, for example, if someone takes prednisone for some other issue and then they stop the prednisone, sometimes they can trigger psoriasis to get severe. Other triggers are listed there. And it can be life-threatening because there is so much surface area affected. There's some loss of electrolytes, hydration in the body. This can lead to a number of issues inside the body. So sometimes people do get hospitalized when they have erythrodermic psoriasis. Nail psoriasis is psoriasis affecting the nails. This does happen a fair amount. Maybe about half of all patients with psoriasis have nail psoriasis. There are a number of changes. The nails get thickened. You can get this yellowish or whitish discoloration distally at the tips. You can get nail pitting, which means that there's tiny little depressions in the nail. And a lot of times nail psoriasis actually can be associated with psoriatic arthritis. So let's talk about psoriatic arthritis. It is the most common associated condition with psoriasis on the skin. So you do have inflammation in the joints and inflammation on the skin. It can happen in there's different reports, but up to 30% of all patients with skin psoriasis have also arthritis, psoriatic arthritis. And of all patients, initially develop psoriasis first. So about 65% of all patients with arthritis, psoriatic arthritis, develop skin psoriasis first and then joint issues. A lot of times 16% skin and joints are affected at the same time. In a number of patients, they do get psoriatic arthritis without actually having psoriasis on the skin. So psoriatic arthritis can affect a number of joints, classically or most commonly inflammation of the finger. So the smaller joints, you can get inflammation of the full finger, of toe, that leads to this appearance called sausage fingers. It's called dactylitis, but it can also involve the spine. So lower back pain can happen, as well as inflammation of the spots where the tendons and ligaments connect to the bone. And this is called enthesitis. A common location is Achilles tendon insertion. Sometimes that can get very inflamed. Definitely, we talked about nail psoriasis, how it can be associated with psoriatic arthritis. And then sometimes people also get peripheral, so knee pain, some other joints, more bigger joints involved. This is an example of a patient with psoriatic arthritis. So you can see here the swelling in the joints, in the distal part of the fingers. This particular patient does have psoriasis on top of those affected joints, and you can see also the nail changes, so nail psoriasis in those affected fingers. And you can see this appearance. This is called what we call sausage digit or dactylitis. So a lot of inflammation, a lot of swelling in these joints. So early diagnosis of arthritis is very important because it does tend to be progressive, the joint damage related to this inflammation, and progression can often result in loss of function. So we always ask patients about joint pain, about any symptoms such as stiffness in the morning, anything unusual that cannot be explained by other things. This is very important to screen. It's very important to screen every patient with psoriasis for psoriatic arthritis because sometimes this can happen, as I showed you before. People can get psoriasis first and then later on develop the arthritis. In addition to arthritis, there are a number of other conditions that have been associated with psoriasis. These are called comorbidities. So again, psoriatic arthritis is the most common, but other important things such as cardiovascular disease, coronary artery calcification, heart attacks, changes in cholesterol, high cholesterol, obesity, certain autoimmune diseases such as Crohn's disease, certain psychiatric diagnoses such as depression. So there's a number of other comorbidities in psoriasis that is important to be aware of, and it's important to ask the patients about. So again, psoriasis is not just a skin disease, and we do want to be aware. We do want to watch out for these other conditions, other comorbidities that happen in psoriasis. And again, the cardiovascular disease is very important. Of course, the arthritis, we talked about that, but these other conditions can also happen in psoriasis. And treatment, of course, treating psoriasis, treating inflammation on the skin can also treat or have an impact on some of these other comorbidities. Although psoriasis generally does not affect survival, patients with psoriasis do have pretty poor quality of life. So there's a significant detrimental effect on the quality of life. And there's numerous studies about this, that this effect can be comparable to some of other chronic diseases such as diabetes, depression, and even cancer. And in addition, the quality of life is poor, not just for the patient, but also family members, relatives can also be affected by this. So this is very important to assess the quality of life of patients with psoriasis, because this can definitely guide treatment decisions. The disease severity can definitely impact the quality of life, and it can warrant more aggressive therapy. And sometimes the amount of psoriasis on the skin might not necessarily correlate with the quality of life. So certain areas, like if psoriasis is on the face, for example, of course, people are more likely to be bothered by it from a cosmetic perspective. Genital psoriasis, of course, can sometimes lead to sexual dysfunction. So, so there's a number of factors that can affect the quality of life. In those cases, we do recommend more aggressive therapy. In the study of a community study of patients with psoriasis, 5,000 about 5,000 people. This was done by the National Psoriasis Foundation, surveying patients with psoriasis, and 94% said that psoriasis is a problem in daily life. 88 said that it affects their overall emotional well-being. More than 85% reported anger, frustration, embarrassment, self-consciousness. 82 said that psoriasis interferes with their enjoyment of life. And a majority of patients, 75% experience itching, 83% experience pain regularly. So definitely these studies have shown that the quality of life is poor, and that we do need to think about this when we see psoriasis patients. It's important to assess the quality of life and direct therapy, of course, to improve the quality of life. So there's a number of support groups out there. I always direct people to the National Psoriasis Foundation. This is from their website, and they definitely provide a number of resources in person and online for patients with psoriasis. So I definitely think that it is very important to seek support and that community. The American Academy of Dermatology also has good resources on psoriasis. So let's talk a little bit about what we can do to treat psoriasis. And again, there's a number of options available. Again, effective treatment of psoriasis not only manages the skin symptoms, but it can also help to reduce inflammation that could lead to other diseases, particularly psoriatic arthritis, cardiovascular disease, some of the other comorbidities. So to understand treatment, we really need to think about pathogenesis, which means how the disease happens. And in the past, people thought that psoriasis is really a disease of the skin cells. There's proliferation, there's accumulation, decreased shedding of the cells that leads to these thickened plaques. But the modern pathogenesis of psoriasis, we now know that psoriasis is an inflammatory disease. So there's a number of immune cells that are they're not regulated properly, and they produce a number of cytokines, which are proteins of the immune system that can affect the different inflammatory pathways. So I'm just going to show you this. This is not to overwhelm you, but talking about pathways of psoriasis and immunity, the most important cell in psoriasis is T cell, which is part of the immune system, and there's different pathways and different kinds of T cells. And when people think that when they're not regulated properly, or there is an imbalance in some of these cells, this affects the skin cells, which are called keratinocytes. And this leads to the skin thickening, erythema, and scale. So targeting certain parts of these pathways is important in order to treat psoriasis. So as far as treatments, we have a number of things available. We have topical treatments, which means anything that's applied to the skin. We have light therapy, also called phototherapy. We have systemic medications, which are pills that can be taken. And we have biologics, which are the modern therapeutics for psoriasis, which are injections or infusions. So we have a number of things available. I just want to emphasize that the best treatment really varies by individual. Like I said before, there's different types of psoriasis. It can affect different parts of the body. So scalp psoriasis sometimes can be a little bit more challenging to treat. Nail psoriasis. The amount of body surface area that's involved is also important. When psoriasis is severe, we do recommend more aggressive systemic medications, as opposed to if there's only a few patches on the skin. And then we always think about possible side effects of medication and the medical history of the patient, because depending on what other diseases or comorbidities patient has, that kind of directs us towards one treatment versus another. So again, for limited disease where we only have a few plaques of psoriasis, we do start with topical agents, so creams, lotions, shampoos, oils, and then we move on towards phototherapy, light therapy, and then the systemic agents listed here and the biologic agents. So of course, as we move from left to right, the risk for potential risk for side effects increases. So let's talk about topical therapy. We have a lot of options available. So prescription corticosteroids, vitamin D3 analogs, anthralin, retinoids, which are derivatives of vitamin A, calcineurin inhibitors, Keratolytics, which means that they get rid of that scale, such as salicylic acid preparations, tar, and moisturizer. So we have a number of things available. By far, the most common therapy that we use is topical corticosteroids or steroids, and they're mainstay in treatment of psoriasis, and they come in various forms. So again, different body parts might require different formulations. It's easier to apply a foam or a lotion, for example, to the scalp, as opposed to a cream or an ointment, for example. They are strongly anti-inflammatory. Sometimes we do use something called occlusion therapy with topical corticosteroids, which means that we apply the medication, or we recommend that the patient applies the medication to the plaque and then wraps the area or covers the area with something, and that basically helps to increase the penetration of the medication to the skin and makes the medication more powerful to treat the inflammation. There's a number of side effects that can happen with topical corticosteroids. We don't really see these when patients use the medications as prescribed. We normally recommend that patients take breaks between applications of steroids. So for example, apply the medication for a week and then stop it for a week, or use it for 2 weeks and then stop it for 2 weeks. So no more than 2 weeks out of a month. Again, the strength of the steroid depends on the body area, depends on the thickness of the plaque. But some of the side effects that some are possible: skin thinning, easy bruising, enlarged blood vessels, change in pigmentation can happen. Also, if topical corticosteroids are used for long periods of time, sometimes their efficacy is decreased, and this is called tachyphylaxis. So again, we do recommend that the steroids are applied with breaks. There are different kinds of topical steroids. So there's 7 different classes. This is kind of summarized here, but we have very, very, very strong topical steroids, which are called super potent topical steroids. And then going down the list to the least potent, which is the hydrocortisone 1%, which is available over the counter. So again, the risk for potential side effects increases, of course, higher risk with the very strong topical steroids. We do want to avoid application of strong steroids on the face and in skin folds or near genitalia, because those can definitely lead to a higher chance of skin thinning, acne induced by steroids, and things like that. Vitamin D analogs, calcipotriene, calcitriol, tacalcitol. So these are also medications that can inhibit inflammation, and they can inhibit the proliferation of the skin that can lead to those thickened plaques. They can definitely be sometimes irritating. We do use these a lot in combination with the topical steroids. And we are careful. They cannot be used in patients who have kidney issues, kidney disease, or abnormal bone or calcium metabolism, or who are pregnant. Retinoids, another class of medications. These are vitamin A derivatives. Tesaratine is one we use a lot. Again, it can help to decrease the epidermal proliferation. It is more of a second-line therapy. We do use it a lot in combination, like I said, with topical steroids. It can lead to some skin irritation. So this is really one of the main limitations for this medication, and is contraindicated in pregnancy and lactation. So there's a number of, so we have a lot of topical therapies available, and there's a number of newer combination medications approved by the FDA. For example, in 2019, a combination of a strong topical steroid with a retinoid was approved in lotion form, or a vitamin D combined to a topical steroid approved in a foam form, which again, it's easier to apply on the scalp. So there's a number of things that usually combination of different classes of medications that can be used successfully to treat psoriasis. Phototherapy means light therapy. So in this method of treatment, the skin is exposed to light. The one we use most commonly is called narrowband UVB. So the light spectrum has UVA, UVB, UVC. We use this very narrow wavelength, 311, 312. And this has been shown to be very effective because it suppresses inflammation in the skin. It can slow down the growth of the skin cells, and it can also be very effective to decrease the itching from psoriasis. So different body areas can be exposed. So sometimes we do phototherapy for the hands and feet, for hands and feet psoriasis, or the whole body can be exposed. This is just an example. It looks like a booth. The patient goes into the booth, and the skin gets exposed to the light for a certain amount of time. Usually it starts with a few seconds and then slowly increases over time. It is a fairly time-consuming therapy because it's done usually 3 times a week for a period of weeks, usually 12 weeks initially, but sometimes longer. Gouty psoriasis, that type of psoriasis that we spoke about earlier, can be very responsive to phototherapy, but other types of psoriasis can also respond very well. So for patients who sometimes don't want to take maybe medicines or injections, this can be an alternative option that can work very well. One thing that's important to mention is that phototherapy is not tanning. So I really want to emphasize that, because some people do try to use tanning beds for their psoriasis, and that's very different. It's very damaging to the tanning is very damaging to the skin. It's UVA light, so it's something entirely different. So we don't recommend anything like that because of the high chance of the risk for skin cancer with usage of tanning beds. Not everybody can do phototherapy. Of course, if someone has already had a skin cancer or a history of skin cancer, such as melanoma or other skin cancers, we do want to be cautious, because even though the amount of UVB that the patient gets in phototherapy is low, it does add to the the damage that the patient already has. Certain patients with medical conditions that such as lupus, that can make the skin more sun sensitive, are contraindicated to use the phototherapy. And there are a number of medications that can make you more sensitive to UV light. So again, those we are cautious when recommending therapy for patients who take certain kinds of antibiotics or blood pressure medications and things like that. Laser therapy is also available. Eczema laser, it's similar to phototherapy in the sense that it uses a very small, so it uses a wavelength of 308 nanometers, which again, these wavelengths of UVB light are very effective to treat psoriasis. The one available is called extract laser, but extract is just one brand of many other brands of eczema laser. And this kind of laser, it applies the light to a very limited portion of skin. So this is really effective or useful when it treats a small area of the body. So if, for example, someone has a couple of patches, they can do this and just treat those particular patches as opposed to exposing the whole body to phototherapy. This can also treat scalp psoriasis, nail psoriasis as well. Systemic medications. So let's talk a little bit about what else is out there beyond the creams and lotions and phototherapy. Systemic medications are pills that are taken either every day or once a week, depending on the type of medication. And some have been around for a very, very long time. So for example, methotrexate is one that we use commonly, has been around for many, many years. Others are newer, such as Apremilast, which was approved in 2014 by the FDA. And these medications, again, for moderate to severe psoriasis, methotrexate is very good when patients also have psoriatic arthritis. These medications do carry a number of potential side effects, which sometimes limits their use. So methotrexate sometimes can be liver toxic, sometimes can affect the bone marrow. So there's a number of potential side effects. And they do require frequent blood monitoring to make sure that it's not affecting those organ systems. So we check the liver, we check the kidneys, we check the blood counts, for example, with methotrexate fairly frequently. Methotrexate can also suppress the immune system. So again, if patients have had certain kinds of infections, this might not be the best choice of therapy. Acidrectin, another medication we sometimes use, doesn't suppress the immune system, but can treat skin psoriasis, but not so much psoriatic arthritis. And so it's a medication, a good medication for skin psoriasis. Cyclosporine, another medication we have, can work very well, very quickly. So in certain situations is used. but again, can have some toxicity on the kidney, and patients usually cannot take cyclosporine for long periods of time. Apremilast is the newest pill for psoriasis that we have available. Again, fairly recently approved, 2014. It doesn't have some of those toxicities that some of the older medications carry, so cannot affect the liver, cannot affect the kidney. So the side effect profile is maybe a little bit better than some of the other medications, and has been approved for both skin and joint psoriasis. So finally, biologics. So biologics are the medications that are newer. They are bioengineered molecules that target specific proteins involved in the pathways of psoriasis. And biologics are the modern therapies for psoriasis. The first one was approved by the FDA in 2004, so it's been a while. They really opened up this new era of treatment for psoriasis, and they quiet down only the part of the immune system that is overactive because of the psoriasis. So they don't suppress the whole immune system, they just target pathways in the immune system. And they have less risk of causing some of those problems that some of the older pills for psoriasis do, such as liver, kidney issues. So that's also very attractive. It can also work very well for psoriatic arthritis. A lot of the biologics are approved to treat both psoriasis and psoriatic arthritis. It can definitely work for the pain, the stiffness, the symptoms of psoriatic arthritis very well. So these work very well. A lot of people clear up to 100%. And there's a number of them that are available. So I just want to give you a sense of where these medications work. So I showed you the different pathways of psoriasis. The earlier biologics are called TNF-alpha inhibitors. So they block this molecule called TNF-alpha. The newer ones block other molecules that are all in these pathways that are known, immune pathways that are known to cause psoriasis. So a number of them have been approved. So we have a lot of options to choose from. Some are approved to treat psoriasis and psoriatic arthritis. There's some that is only approved for psoriasis, some is only approved for psoriatic arthritis. But again, they all work very well. And usually they're given either as an injection or as an infusion. And the first generation adalimumab, etanercept, infliximab, they do block the TNF-alpha molecule, and some of the more recent ones, they block other, like I showed in the previous slide, they block other molecules that are important in the pathways of psoriasis. And so the first biologic was approved in 2004. The most recently approved in 2019 is Resancizumab. Again, we have a range of options available when it comes to biologic medications. Not everybody responds to biologics. Sometimes we do start with one and then we go to a different class of biologic if patients don't respond to that one particular biologic. Also, sometimes patients that have psoriasis and psoriatic arthritis respond very well on the skin, so they completely clear the psoriasis, but they might continue to have joint issues. In that case, we either change to another biologic or we add other medications such as methotrexate. In terms of side effects, so the long-term side effect profile of biologics has been very good. Each individual biologic can have its own list of possible side effects, but in general, the common side effect is really increased risk for developing infections and skin reactions where the biologic is injected. Again, the long-term side effect profile is very good. And we know that because there's been a few studies, especially with the biologics, that have been around for a long period of time. So, so my next part of this talk, I do want to talk about more practical tips for managing psoriasis. This is from the American Academy of Dermatology, has a psoriasis center with information, but it's important to think about what can we do at home, and if you have psoriasis, what can you do for your skin, and what are the things that you should be doing for your skin. By far the most common or the most bothersome symptoms of psoriasis is the itching. A lot of people have severe itching with psoriasis. So what can you do to address some of that itching? So again, most important thing is to treat the psoriasis. So the best way to get rid of some of the symptoms, especially the itching and psoriasis, is to treat the psoriasis with with some of the medications that we have available. You can try to remove the scale by using a salicylic acid-based medication. It's very important not to scrape the skin, not to try to peel off the scales, because trauma to the skin can actually worsen psoriasis. You want to limit shower time because spending too much time in water can actually dry the skin and can make that itching worse in your skin. And it is very important to use a good skincare regimen, use moisturizer. So you can apply a moisturizer cream or ointment after showering, after bath. And the moisturization can help reduce the redness, reduce the itching. It might not treat the inflammation in the skin, but it can definitely help. And there are over-the-counter anti-itch products such as Sarna lotion, which contains menthol. Those can also be a little bit helpful. It's important to moisturize instead of scratch. So scratching, trying to remove, exfoliate, remove the scales, peel the skin, can be very detrimental because trauma can make psoriasis worse. So instead of scratching, it's important to grab your moisturizer and moisturize the skin, and that way that can definitely help to soothe the skin a little bit. It's important not to take hot baths because hot baths and showers can actually make you more itchy, can dry the skin more. Then you can always try to apply a cool compress to areas that are itchy. They can definitely relieve some of the itching and basically numb some of the nerves that transmit itching in the skin. Lifestyle is also important. As I mentioned before, psoriasis is associated with a number of other comorbidities. And so certain lifestyle factors are very important. Self-care measures can help better manage psoriasis. We talked a little bit about the skincare regimen, the moisturizing, and the not scratching. It's important to avoid psoriasis triggers, infections, injuries to the skin, stress. Smoking and alcohol have been associated with triggering psoriasis and making psoriasis worse. There's definitely an association with psoriasis and smoking and alcohol. So there are studies showing that when someone quits smoking, psoriasis gets better. And of course, the risk of some of those other diseases, such as cardiovascular risks, also decreases. You can try to expose your skin to small amounts of sunlight. So sometimes we do tell people in the summer, you can expose the skin, the affected skin for 10 to 15 minutes to direct sunlight, but nothing beyond that, because if you get a sunburn, that can actually, it's trauma to the skin. So that can make psoriasis worse. Also, no tanning, as I have mentioned previously. Tanning in a tanning bed is very bad for your skin. It can make psoriasis worse, the sunburn reaction, and it increases your risk for skin cancer. It's important to maintain a healthy lifestyle. So things like being active, exercising, having a good diet, those can definitely help. Maintaining a healthy weight, those can definitely help with psoriasis, but also with, like I said, decreasing some of those comorbidities in psoriasis. So in conclusion, psoriasis is not just a skin disease. As we've seen in this talk, there are associations with other diseases, and effective treatment is important because it can treat both skin symptoms, but also those associated diseases. There's many options for successful management. Again, we have creams, we have pills, we have injections, but it is very important to individualize treatment for every patient because every patient's situation is different. Their comorbidities might be different, the medication they take might be different. And finally, lifestyle factors are also important in psoriasis. So that's all I have today. Thank you so much for your attention. I will take questions now, and I'm looking forward to your comments and suggestions if you have any. Thank you.
Thank you so much, Dr. Fedeles, for a wonderful presentation. We are now at the end of the session, so if you have any questions, please ask them in the chat box. Okay, so we have a few questions that came in. One being, you had mentioned earlier in your presentation about family history, first degree relatives. Can you define what that means?
So first degree parents, children, second degree relatives would be cousins. That's essentially what that means. Psoriasis does tend to be underdiagnosed. So sometimes, patient might have psoriasis and actually not know about it. So it's not a given. A lot of times we see patients who say nobody else in my family has psoriasis. And again, if someone has psoriasis in your family, it's not a given that you're going to develop psoriasis either. There's many different factors there, beyond the genetics.
Okay. And then you had mentioned phototherapy being one treatment option. Is that done in the clinic?
Yeah, so we have a phototherapy center where we do have these phototherapy booths. And essentially, we see the patient, recommend phototherapy, and then the patient goes to the phototherapy center and then gets the therapy done. Usually about 3 times a week, initially for 3 months. And then sometimes either the therapy is tapered over a number of months or sometimes it's stopped, depending on the individual situation.
Okay. You had also mentioned moisturizers. What key ingredients should one look for in a moisturizer?
So there are different things available. We do think that more greasier moisturizers, such as Vaseline, Aquaphor, those are a little bit better and keeping that moisture in the skin. Some people don't like when the moisturizers are greasy. Creams are also available. I do like creams that have ceramides in them, such as CeraVe, Cetaphil, but they're used for, and there's a number of options available. And so there's no key ingredient necessarily. I would say that the most important part is consistency when it comes to moisturizing. So after every bath or shower, patting the skin and then applying immediately the moisturizer.
Thank you. And do you have any recommendations on diet? Does decreasing dairy or sugar help at all?
So there isn't really a lot of data available. And so there is maybe a little bit of data saying that perhaps omega-3 fatty acids are beneficial or taking supplement, but there's not really a lot of data in general about diet. Having a healthy diet is important because psoriasis is associated with obesity, with diabetes, cardiovascular disease. But elimination of certain things from diet has not been shown to be necessarily beneficial. I tell people if there is something that you feel that is really worsening your disease, like let's say that you drink milk and you feel like you're getting worse, or you stop drinking, you stop using dairy and you get better, then you should continue doing that because it's something that's working for you. But in general, there's really not a lot of data available.
Is psoriasis related to poor liver function at all?
No, not really. But when someone has poor liver function, it does prevent, it's a contraindication for a number of those medications, such as methotrexate. And even biologics, we do screen for certain diseases before someone takes a biologic, and that includes hepatitis. And so if someone has certain kinds of hepatitis, they cannot have a biologic medication, they cannot have certain kinds of medications. So liver disease doesn't cause psoriasis, but it can prevent some of the treatments for psoriasis, unfortunately.
We'll give it another minute to see if anyone else has questions for you. If someone suspects that they have psoriasis or irritated skin, what would be the next step to get to be seen in the dermatology clinic?
So it's important to see a board certified dermatologist so they can make an appointment in our dermatology clinic. What we do is we look at the skin, and based on the appearance of the skin spots, we can sometimes tell what psoriasis is and what it's not. Sometimes it's not entirely clear. So sometimes we do perform a skin biopsy if we are not really 100% sure that the patient has psoriasis. So sometimes they can help us make a diagnosis. Most of the time, psoriasis is more of a clinical diagnosis. So we look at the skin, we look where the spots are, and we could tell whether it's psoriasis or whether it's some other chronic inflammatory skin disease such as eczema.
And are you currently seeing patients virtually, only in person?
We see both. We see both in person and virtually. So we do teledermatology, and we have a number of appointments available. So yes, we do both.
What is the incidence of Caron's disease and psoriasis?
Of what disease?
Caron's, C-A-R-O-N.
Not familiar with these. As far as I know, there's not really a correlation, but I'm not really sure, so I can't really answer that question. I'm sorry.
You listed coal tar treatment. I had that treatment years ago. What does it actually do to the skin?
So coal tar has a few beneficial effects in psoriasis. There is this older protocol called Geckerman where people used to do tar and phototherapy together. We don't do that anymore. So tar has anti-inflammatory properties and can also help to thin the skin in psoriasis, to help the itching and some of those thickening of the skin. But it can be irritating to some people. Some people do think that it has some carcinogenic effects. So there's limitations to its use. So it can be irritating. Also, there's an odor to the tar. So some people might not like to apply that to their skin. It can definitely, we use it in combination. So there are a couple of over-the-counter tar preparations, which I think are good and can be used. And we usually do use them in combination. So sometimes might use a topical steroid, might use a vitamin D analog, might use a tar, and kind of alternate between different treatments.
Mm-hmm. I believe you covered this, but would you be able to elaborate more about would prolonged sun exposure worsen psoriasis?
Yeah, so any damage to the skin can trigger psoriasis or can make it worse. So sunburn. So we really caution people because it's very hard, right? Depending on the skin type of the patient to really know, oh, I'm going to use, I'm going to spend 10 minutes in the sun and not get a sunburn, or I'm going to spend 20 minutes in the sun. In general, for when people want to do to get their skin exposed to sunlight, we say 10 to 15 minutes, and that's it, because beyond that, there's a high chance that people will burn, especially if they're lighter skin types. It's important to wear sunscreen. Sunscreens are very important and very good at prevention of skin cancer, and so a little bit of sunlight, but beyond that, we do want to be very careful with sun protection.
So with the recommendation of no more than 10 to 15 minutes, would that be with or without sunscreen?
Without sunscreen. And then after that, application of sunscreen immediately. So again, so as not to burn the skin or increase the risk of skin cancer.
So we'll give it another minute to see if anyone else has questions. In the meantime, do you have any final thoughts you'd like to share with the audience?
Well, thank you for having me. Psoriasis is a topic that's near and dear to me. So if anybody has any suggestions or comments or questions, we are available in our dermatology clinic. So
I do have a question that came in. Do you have any recommendations for nail psoriasis care at home? Any hand cream, anything to help with nail peeling?
So nail psoriasis can be tough. There is inflammation both in the nail bed and also in the nail matrix, which is that part of the nail that actually makes the nails, so that can lead to a number of changes. You can definitely try to moisturize. Using a salicylic acid preparation sometimes can help to reduce some of that scaliness. In clinic, we sometimes inject steroid medication, corticosteroid, in the nail matrix. It can be a little bit uncomfortable. They can suppress that inflammation in the nail. Definitely moisturizing is important. Avoidance of potential irritants. So I would probably avoid manicures, avoid chemicals around the nails in those situations.
Is irritable bowel syndrome common in psoriasis?
So Irritable bowel is a little bit different than inflammatory bowel disease, which is, we think of inflammatory bowel disease, autoimmune, Crohn's, ulcerative colitis. Those tend to be common. Irritable bowel, perhaps not so common. Irritable bowel tends to be a common disease in general,
Mhm.
right? So not one that is necessarily associated with psoriasis. Definitely patients can have both of those things.
It seems like eczema and psoriasis can have similar symptoms. What are some big differences between the two?
So psoriasis and eczema are very different, and that comes from their pathogenesis, which means that there's different pathways in the immune system that are not properly regulated, let's say. And so the appearance is very different. In eczema, the plaques can be thickened from scratching. Itching is a very common symptom in eczema, and the locations are different. It can happen. So, for example, psoriasis goes to the elbows and knees, while eczema would go to the inside of the elbows. So the flexural, the inside of the elbow behind the knees. So the location of eczema tends to be different. The appearance of eczema, usually it's not so thickened and it's not so dry. Psoriasis definitely has much more redness, thickening, and dryness.
Mhm.
And it has that specific, what we call silvery scale of psoriasis. But there's certain appearance of the scale that looks different in psoriasis versus eczema. So again, psoriasis goes in very specific areas that eczema might not go to. So the appearance is different. The locations can be different. And some of the symptoms can be different as well.
So when in doubt, see a dermatologist to get the proper
Yes,
diagnosis.
yes. There definitely can be an overlap. So in certain situations, for example, on hands and feet, so sometimes a type of eczema called dyshidrosis can definitely present with blisters that are itchy, and
Mhm.
so can psoriasis of the hands and feet. So sometimes it's not such a clear cut diagnosis. And sometimes, like I said, we do skin biopsies to just further investigate and see whether we classify something as a psoriasis or eczema. Some
Mhm.
of the treatments can definitely be similar. So some of the topical treatments, especially the topical steroids, can be very similar. But beyond that, some of the other treatments are very different, such as the biologics, which are for psoriasis.
Mhm. Okay, so we have someone who is asking, I've recently tried using gel-lined gloves for the patches on my hand. It has helped my skin sores heal. It's working for me, but are there any reasons I should be concerned about using these gloves? So these are bought online.
Um, so I'm not familiar what exactly is in those gel gloves. Definitely we recommend gloves, usually cotton gloves for occlusion therapy. So we recommend that people, especially if they have hands and psoriasis on the hands and feet, they apply the medication at night before they go to bed, and they put socks and gloves on, usually cotton gloves, because help, those are better for the skin to breathe a little bit more, and that can keep the medication in place and can make the medication stronger. Also can prevent scratching, right? So it's a barrier. So definitely wearing gloves in general on, with medication can be helpful. Can't really endorse those particular products because I'm not familiar with what exactly is in those gel gloves, but gloves themselves, or covering up areas of psoriasis with gloves or socks, that can be beneficial.
So one final question. Is there any research for psoriasis being conducted where patients can enroll?
Yeah, there's many clinical trials. There's a number of newer, like I said, the most recent biologic was approved in 2019, which is very recent, but there's always medications, biologics or other medications in clinical trials, and there's definitely ways to enroll in those trials. The NIH has a website where you can look at all the clinical trials available, and then usually hospitals do have, we have our clinical trials unit called Curtis. We have other, every hospital has their own clinical trial unit where they enroll a number of patients in clinical trials. And so definitely getting in touch with those clinical trial units is important to find out what is available as far as clinical trials for psoriasis.
Can they call the dermatology department to see if there's a
Ye-
number to get, someone to get in touch with
Yes.
regarding?
I always direct people to our main dermatology number. We have this one number for everything. And then from there, you can actually ask to be connected to talk to clinical trials, to talk to individual providers, and so on and so forth.
Great. All right, so we are right about that time. Thank you so much, Dr. Fedeles, for a wonderful
Thank you so much for
presentation.
having me. Thank you.
Thank you so much, everyone, for joining us today. As mentioned, today's session was recorded. It will be posted on our website at massgeneral.org/Blum-Center. I would give about a couple of weeks for it to be online, but it'll be there. Once again, thank you so much, everyone. Have a lovely rest of the day.
Thank you. Bye.